we could have the official start. Yes, thank you. I just want to acknowledge that we are basically in Manitoba on stolen land, and the families of the women that are missing in the landfill have asked that we not do land acknowledgements in the usual way until the landfills are searched for the bodies of the missing 3 women. And I believe we're making good progress in that direction. However, it has not necessarily taken place yet. So I just want to say we acknowledge that much of the land we are on in Manitoba is stolen. And on behalf of the Green Party of Manitoba, we ask all to support that the treaties be honored. They have not been honored in Manitoba, and many continue to not be. So as our acknowledgement, we ask that the treaties be honored and that we do what we can to ensure that they are. I am very delighted to introduce our 2 speakers this evening. I believe Dr. Charlyn Black is going to start. And then after, I think between 15 to minutes to half an hour, we're going to move over to Dr. Sande Harlos. And you may, just to refresh your memories from what has been sent out, is that Dr. Black is a professor at the UBC School of Population and Public Health. She's nationally recognized she's a nationally recognized health systems and policy researcher, and was formerly a founding member and co-director of the Manitoba Centre for Health Policy at the University of Manitoba. Dr. Sande Harlos is a retired public health physician who served the Winnipeg public as a medical officer of health for over 25 years. Wonderful service. She's currently the volunteer president of the Manitoba Public Health Association. And Dr. Harlos is passionate about our shared responsibility to close inequitable health gaps through healthy public policy and community engagement. Values we certainly share here at the Green Party of Manitoba, with our core values being health, ecology, fairness, and care. And with that, I don't know how applause comes across on Zoom, but I'd like to ask you to join me in welcoming our guests, and specifically Charlyn Black starting. So, Black, welcome.
Dennis, can I ask for the slides, please?
And while Dennis is pulling up the slides, I'll just say our speakers tonight have kindly agreed, if you have questions during their talks, to please share your questions. If you have comments, I'd ask that you hold them to our Q&A section. And if you're so inclined, we would love, and our guests would love, to see your attentive faces. So if it's at all possible, we do welcome that you have your camera on, if at all possible. So thank you so much, and please go ahead, Dr. Black.
Okay, I will just say that we're not going to do things with me speaking for 15 minutes and then Sande speaking. Sande and I have worked hard to coordinate and go back and forth a bit. So, and we are looking forward to interaction with you as well. So we were asked to speak on the social determinants of health, and we've actually learned lots in putting together this presentation, both of us. So we hope to share some of that learning with you. Next slide, please. I do have a land acknowledgement. I'm from BC. I will say that both of us have BC, both Sande and I have BC and Manitoba roots. Sande was actually born in BC and has become a Manitoban. I'm a Manitoban who migrated to BC. So I'm joining you from territories that were never formally negotiated, that were stolen from Indigenous nations, and just want to acknowledge my own responsibility in furthering action on reconciliation. So next slide, please. So for the agenda, I'm going to start with an introduction. Sande's going to really provide an overview and basic concepts, and talk about how the concept related to the social determinants of health have evolved over time. There's been a real long learning curve here. And Sande's going to talk about that. I'll spend some time on, how can we bring policy approaches to address the social determinants of health? And then we will have interaction during, but hopefully enough time for questions and discussion at the end. Next slide, please. So the social determinants of health, a relatively new term in health and healthcare. And it was defined initially in some discussions about population health that actually took place in Canada. But it became defined by the World Health Organization in a formal report as the non-medical factors that influence our health outcomes. The conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems that shape the conditions of our daily lives. And these forces and systems include economic policies and systems, social norms, social policies, and political systems. And they're clearly shaped by the distribution of money, power, and resources at global, national, and local levels. They have an important influence on health inequities, the unfair and avoidable differences in health status that we see between and within countries. And in countries at all levels of income, health, and illness follow what we call a social gradient. The lower the socioeconomic position, the worse the health. This is absolutely across the board. Next slide, please. So I'd like to ask audience participants to guess. When we think of health policy, we tend to think of our medical care system. How much of an impact do you think these non-medical factors have on health relative to our medical care system? I won't call it a health care system. Any guesses? Anyone want to take a guess? Speak up. Okay, Janine, you go.
Well, Lockhart put his hand up first. So Lockhart,
okay.
Cookie, go ahead. What do you think?
Actually, I was signing big.
Oh, okay. You were signing big.
I'm expecting a large number.
Yes, and I as well. I'm thinking that access to food is not equitable in this country. And I know we have way too much child poverty in Manitoba. And I'm thinking access to healthy food. Folks don't have access to 2 cups of vegetables and 2 cups of fresh fruit a day every day. So that's my contribution.
Anyone want to take a guess at a percentage?
I'm thinking it's 50-50.
50-50?
80%.
Well, 80% which way, Tom?
That need help.
Social determinants impact 80%. That's what I would say. Yeah. Over 75%, I would think.
Other thoughts? Tom, you're actually right. It's hard to estimate this, actually. But, and some estimates have been, our medical care system contributes as much as 10 to 20%, and the rest are these non-medical factors. So if I can have the next slide. This is, I think, from the King's Fund health policy group in the UK that I thought developed a really nice rubric to look at the things that influence our health. And you can see that, there are individual factors. Around that are individual lifestyle factors, social and community networks. But then under general socioeconomic, cultural, and environmental conditions, you're absolutely right. Janine, you talked about agriculture and food access, right? Education, work, living and working conditions, employment, water and sanitation, housing, and healthcare services is just one among many of these larger conditions. So absolutely, these are much more important at creating health. What we have with our medical care system is a system that focuses largely on disease. To some extent, prevention, but largely it's disease focused and focuses on treating sick people or people when they've identified they're sick. Next slide, please. This is one rubric. There are some of these, but it's really hard to research the impact of these various determinants of the social, the impact of the various social determinants of health. This particular estimate estimates physical environment as 10%, social and economic factors as about 40%, clinical care 20%, health behaviors 30%. But there are so many ways to cut this up and look at it. But you know, in total, we're only thinking about 20% comes from the medical care system. And yet most of our health policy focuses on the medical care system, right? Access to medical care is so prominent in policy discussions. So with that, I'm going to now turn it over to my partner, Sande, who's going to really take you through and talk about the social determinants of health and how that concept has evolved and shifted over time. Sande, over to you.
Okay, thank you. So next slide, please. So before I jump in, I just want to say, echo Charlyn's comments that I really appreciate being here tonight and looking forward to the discussion that we have either at the end or throughout, because I think that I've got a lot to learn as well. This is certainly an area that we never stop learning. So really excited to hear some comments and thoughts. And also, I just want to recognize and say I'm respecting, and my heart is with the search of the landfill. And I'm also coming from lands in Winnipeg and Manitoba, and as a white settler, commit every day to become a better ally for the sovereignty of Indigenous nations on these lands. So just to emphasize and actually back up a little bit from the definitions of social determinants of health, because really the social determinants of health came from a little bit broader concept of determinants of health in general. And it started out with a whole bunch of different lists. So you can see the kind of lists here where we have certainly biologic and genetic endowment. That's a big part of our health, but not anything that's modifiable. And also access to health services. And so we just saw that really the access to medical care specifically or health services is really only responsible for a small portion of our health. Certainly an important thing to have when you're ill or injured, but really all these other conditions that are modifiable are the ones that we label as the social determinants of health, and the ones that we think that we can do something about to improve the health of the whole population, and more importantly, to close health gaps. So we can go to the next slide. So the concept, though, of social determinants of health is so much more than a list. And certainly if you Google it, you'll find all sorts of different lists that have evolved over the past decade or two, and all sorts of models and diagrams and frameworks and so on. I've circled the social determinants of health because that's what we're talking about today and what Charlyn defined earlier. But there were sort of two main parts that came out with the social determinants of health concept, one being the conditions of everyday life. And those were the things Charlyn mentioned, like the everyday social circumstances, access to healthy food and housing and sufficient money and early childhood development and those kinds of things. But the other thing importantly that she said was also the distribution of power, money, and resources throughout society. And what happened over the last decade or so is that in the application of the concept of social determinants of health, there was much more activity that's centered on the conditions of life, conditions of living, and not very much efforts to shift the structure or the components that were sort of the drivers of those conditions, which were seen as that distribution of money and resources and power specifically. And so new terminology started popping up, and now we've got a whole bunch of terminology out there in this realm of social determinants of health. But people have tended to shift to using the word structural, to looking at the parts of the social determinants of health that are really the underpinnings or the deeper than the conditions, and the things that are about the distribution of power and resources in society. And then just to throw a few other terms out there, some of that has been sort of subcategorized into political, ecological, economic, and commercial. So you can fine tune all of these kinds of elements that are really about the broader context of our life and not so much about medical or health care. I want to say a little bit specifically about the determinants of Indigenous health, and that certainly is a big focus and needs to be a big focus in the point of history we're in, and knowing that there are significant health gaps that are experienced by our Indigenous peoples across Canada. And certainly there are some differences when you try to frame this broad concept of what creates health from an Indigenous perspective. And I certainly recognize I'm not best placed to speak to those concepts because it really should be framed and discussed by someone with an Indigenous worldview. But some of the elements to point out that are different is certainly that very much a place-based approach, and the connection to land, and specifically land and water and the natural world, is certainly an important component of determinants of health from an Indigenous perspective. And focusing a lot on the life course, and not just one specific sort of lifespan, but the recognition of the connection with ancestors who have been before and still are part of this realm, and the generations to come. So there's a very different perspective about health that comes from that linkages to your ancestry and to thinking about the generations to come. And certainly culture, language are important determinants of health, as well as self-determination and sovereignty. So those are things that would facilitate health from an Indigenous perspective. And then things that get in the way, certainly the big driver would be recognizing the impact of colonization. And so colonization, racism, marginalization, all of that is certainly a very big ongoing force in a barrier to health from an Indigenous perspective. So next slide. Okay, I think did we skip one? I think there was one that was meant to be before here. That's if we don't have that one, that's okay. Okay, no, that's okay. I will, at the end, I'm going to tell you a resource, because there was a diagram before this one that is in a resource I'll let you know later, but there's a document that showed sort of a framework that was a tree diagram that was done by an Indigenous perspective, written in a document about the social determinants of Indigenous health. So we've skipped over that one a little bit, but I will just say that this tree diagram that we have in front of us here really borrowed from the document that was written from an Indigenous perspective. And as I mentioned, there were so many frameworks and models and diagrams to try and describe this concept of the social determinants of health and all the different aspects of it. This is one fairly recently done by the National Collaborating Centre for Determinants of Health, and they built on the concept of a tree diagram. And the reason for that is that often the diagrams that you see are kind of static, and using a tree really borrows from the natural world and the understanding that all of these things are dynamic. They're not static. They draw from one part and have impact in other parts. And it's ever changing and ever moving and ever living. And so the tree diagram, I think, is a really good way to take those lists or to take those frameworks that we talked about before and actually organize it, because we have to organize our thinking a little bit if we're wanting to make impacts into actions on the social determinants of health. So in this diagram, at the very beginning, at the very top of the tree, you see leaves, and those are sort of the physical and mental health outcomes that we typically think about when we measure the outcomes of health and certainly the impact of health inequities. So those are important because we are meant to monitor how we are doing with the social determinants of health and the health outcomes. So you can see that those are things like health status, things that we would measure. The trunk is about individual behaviors, and we saw individual behaviors when we looked at the list of determinants of health. But over time, we've learned that that telling people what they need to do about an individual behavior is not does not make impacts in changing health status of populations. So those things we just kind of want to move aside and think deeper into the roots. And so in this model, the roots are kind of the conditions of daily life. So the kinds of things we talked about that like work or housing or income, sufficient food, healthy environment, and those kinds of things. But importantly, the where those roots draw from is the soil underneath that. And that is where you have underlying values, worldviews, policy, practices. This is where the distribution of power, money, and resources kind of is sourced from. And so when we think about the determinants of health, we want to think through those layers and think about how dynamic that those layers are. Okay, next slide.
Sande, if I could pause for just 1 second, and I think we can get that other slide back up if you don't mind me trying.
We're not missing a lot by not having it, so I don't think if it's difficult to do, we don't need to do that.
Okay, while we get back on the slides, I'll just add from an agricultural point of view, when you see a tree growing, know that the roots have as much or more mass than what you see of the tree. And so I think that's a good parallel for what we're seeing in terms of all the impacts that all of the many factors that impact the leaves, which actually, shows what the health outcomes are in the end. So.
Yeah, so that looking to the natural world for models and instruction, I think that's a really important visual. I love how you pointed that out. Yeah, absolutely. Thank you, Dennis, for going to find the lost slide there.
Thanks,
so
Sande.
this one predated the one that came up a little bit before, and so it's the social determinants of Indigenous people's health. So you can see there's some real commonalities. But in this case, what they've broken it down into the stem determinants, the core determinants, and the root determinants. And so the roots there, I guess if they diagrammed it, as you said, Janine, that should have been a much bigger portion. So let's just imagine it is.
Yes.
And in the description around that model, they certainly look at the, colonial factors the need for Indigenous self-governance, the roots to be really the source of everything else. Like it is very, very foundational. And then the stem and the determinants are a little bit more like what we were talking about. The stem determinants are a little more like the conditions that we were speaking about before. So, and the reading about the model, they're really thinking about this being fluid and very dynamic. So certainly the things like employment and income and education and food insecurity, some of the things people might more easily understand or describe in the social determinants of health, they're really much more importantly influenced by those systems, the rules of society, the distribution of power, and those foundational structures that actually determine the conditions. So it's sourced in that way. So there you go. And I will maybe just mention to that in the discussion of this document, they also made the analogy of an invasive species, just because you're talking a little bit about, sort of in real agriculture and real natural forests and so on, that an invasive species coming in and the impact that has to an ecosystem. And they use that analogy to talk about colonization and what that has done to the health of Indigenous people. So it's a good analogy. Okay, let's move on from there. Thank you for finding that one. Okay, so we've been using the word health equity now and again already without really defining it. But when we talk about social determinants of health, that concept goes hand in glove with the conversation around health differences or health equity. So certainly there's differences in health for a lot of different reasons, but the ones when we have an inequitable distribution of social determinants of health, and by that I mean the conditions of living as well as that distribution of power, resources, and money, then you inevitably result in an equitable distribution of health. And that results in health gaps, where we see that people that are living in a variety of marginalization circumstances or affected by the social determinants of health in an unfavorable way will have different and lesser health outcomes than people with more advantage. So next slide. So I did a little number crunching, and I wanted to give you a little bit of an example, and I won't try to get too deep into the numbers here, but I picked a particular indicator that came from a source from the Manitoba Centre for Health Policy. They put out indicators, which are little health snapshots. And so this is from the 2009 RHA Indicator Atlas. And one particular measure would be of the number of days people spend in acute care hospitalization. And this is adult. And it's broken down by income quintile. So income quintile is a measure that's often used as a proxy for social and economic status. And it really takes, this is Winnipeg data, and it is breaking Winnipeg into 5 different income quintiles. So the lowest income quintile is their number 1 up to the highest income. So what you see there when we map out or graph out the number of hospital days for acute care situations by income quintile is you see that the people in the lowest income quintile have quite a lot of higher need for hospital days than people in the highest income quintile. And the gap is actually such that from the highest to the lowest, there's double the number of hospital days that people in the lowest income quintile experience compared to the highest. And so we can go to the next slide. And certainly anybody interrupt and if you have any questions about what I'm throwing at you here. So I did this little thought experiment saying, but if we didn't have differences in the social determinants of health, what if everyone had the same health need for hospitalization as people who were had the most advantaged amongst us in Winnipeg? So you draw a little picture and you take the population numbers and the population rates of hospitalization and you say, what if everybody had the same rate as the highest income quintile? And you can see that the acute care hospital days would be reduced by 1/3. So this is just a way of trying to wrap our heads around and quantify the theoretical notions of what would it look like if everybody was experiencing their best possible health. And again, using hospitalization as a marker of when you've had a challenge to your health. So when you think about that, you know, our hospitals are very crowded and our budgets tend to focus on the needs in the acute care system. And if you looked around at a very full hospital and then all of a sudden 1 in every 3rd bed disappeared because we had no differences in the social determinants of health, that's the kind of impact we're really looking at. So next slide.
And I'll just add, that would be if we had social justice.
Yes. Yeah, social justice is really down there in the soil with the roots of those trees. Absolutely. So if we had social justice that then went up through the roots of the trees, resulted in similar conditions, resulted in similar health outcomes, then we would end up with reducing the need that we had on our acute care system and our healthcare system. So it was there for everyone when they needed it, but that there weren't preventable and unjust reasons that people were experiencing poor health and needing higher rates of healthcare. Exactly. Okay. And then I took my experiment a little bit further and just said, well, okay, this was a 5-year period of time that we were counting the hospital beds. So if we actually said, well, what does that difference amount to? That would mean we could reduce the beds in the hospitals by about 133,000 days a year. And if a hospital day costs on average, and this is just an if, this is all hypothetical, $1,500 to $2,000 a day, then we'd be talking at, in just this one specific health area, a $2 million difference a year. So these things, this is just one small sort of thought experiment, but when people say we don't have the money to invest in social determinants of health, this is just a way to wrap our heads around that we're paying for differences in social determinants of health right now because of the impact that the differences in social determinants of health have on people's health and our other systems too, of justice and education and a variety of other systems. Okay.
Is this across the country? Sorry. Is this across the country or just in Manitoba?
This data was actually from Winnipeg data because we just had data available that looked at certain indicators by income quintile. So these patterns would be true across country, but this figure here was just for hospitalizations in Winnipeg.
Wow. Okay. Thank you.
Yeah. Yeah, but the same pattern would be seen across the country when you break
Right.
down our statistics by income, which knowing that income is just a proxy for social economic disadvantage related to like not having determinants of health. I know there's something coming up in the chat, but I'm wondering if someone's monitoring the chat to be able to let me know if we should be stopping for questions.
Greg is just asking if you have any more specific data or information on the hospitalizations. I'd be interested in understanding a more specific breakdown on the details of the hospitalization needs. How are the needs of clients different across socioeconomic quintile?
Yeah. So there's the study that the data report that I mentioned is available online. People can look at that RHA indicator data, and they did break down lots of different indicators by income quintile. So that's a kind of a common way to look at trying to get a picture of the differences across populations by income as a proxy for socioeconomic status. This one that I picked was only acute care hospital days because it's not your whole hospital stay. You might stay in the hospital, get treated for an acute care, medication or surgery or something. Then you might stay in the hospital longer because maybe you don't have a home to go to, or maybe things need to get set up before you go home. That's a different statistic. So this one here is really just a proxy for severity of illness. So what it is saying is that people that are living with bearing the burden of the unequal distribution of social determinants of health are just sicker across the board. So that's kind of what the picture that's giving us. I'm not
and
sure.
If I can just add, Sande, I think that largely, so these are acute care and they're largely for preventable conditions. But there's a difference in distribution across the income quintiles. And the other thing is because this is just acute care days, it largely underestimates the dollar savings per year to Winnipeg hospitals if we would include those stays because people didn't have housing to go to, etc.
Quick question. About the quintile, the economic quintiles, do you have a more precise definition of what it means to be in the lowest quintile and the highest income quintile? Like, are there dollar figures that you can attach to that?
Yes, there are, and they're in the RHA Atlas. And what they do, and it's one of the things that Manitoba Centre for Health Policy does and has really worked on their methodology over the years. So they have a very specific way of breaking down populations into income quintiles. And it's basically finding the income distribution that puts people into about 20% of the population in each group. So there is a table resource. I don't have it with me right now, but maybe when Charlyn's talking, I can look it up for you. Certainly there's a bigger spread in the lowest income quintile. But there are tables that basically it's based on it's sort of an ecological way of doing it, and it's estimating a household income.
Yeah, and I guess a related question, and forgive me because statistics is not my forte, but when we're talking about quintiles, are we talking about 20% of the population or 20% of some kind of income?
Yeah, 20% of the population. So if you basically just said the Winnipeg population, and let's spread everybody's income out, and then we take what is the income spread that comes with the people, 20% of the population who is getting the lowest income. What does that income spread look like? And what's the next 20%? And what's the next 20%? And the idea to do that is to show that there's gradients in health. It's not just sort of have and have not, two groups or anything like that, that this distribution of health related to the distribution of social determinants of health seems to operate on a gradient kind of basis.
Okay,
so
thanks.
It's 20% of the population of Winnipeg in those particular groups. So I'll try to look up that table and see if I can circle back to you while we're talking here.
Okay, thanks.
Okay, moving along, next slide then. Okay, so we did talk about Oh, talking about the opportunities. So how to address the social determinants of health. So this is the same tree picture, but the point I'm just trying to make there, the little box that they have in red, if it's hard to read, the opportunity for public health to redistribute power for health equity, collaborate across sectors, partner with community organizers, and engage with social movements for social justice. It's really calling on us to work on the roots and below the roots, and not spend a lot of time on healthy behaviors, and telling people what they need to do at an individual level. So if we want to address social determinants of health, we need to go dig deep. So that's the call to action there. Next slide. So how do we do that? I just want to introduce the concept, and I think Charlyn's going to be talking a little bit later about sort of how to address some of the unequal distribution of social determinants of health. But there's a concept that's been around for a while, and it's a good concept. It just needs to be, fully implemented, called health in all policies. And it recognizes that, again, population health is not just a product of the health sector. That's what we've been talking about all night, but determined by the policies that guide actions beyond the health sector. So it's calling on every sector in government has a role to potentially affect health and inequities in health. So it's trying to bring a health lens into policy decisions that are made in other departments in government outside of health. Next slide. So, when we're sitting talking about this, we say, well, that, I hear people say, well, that's just a no-brainer. Like, yes, we know we need to move upstream. We know we need to get to root causes. We knew we can put this policy in action and do a health in all policy approach across government. And it sounds so easy. But if it was so easy, then we'd be making a little bit more progress, I think. So these are just some of my ideas, and I'm interested in other people's ideas as we have more time to have dialogue as well. But what are the barriers to the action on social determinants of health? Because the definition that Charlyn presented was from, there was a document of closing the gaps in a generation, which was 16 years ago, and we haven't closed those gaps yet, and we're getting close to a generation. So let's be realistic. What are some of the barriers? Well, one thing I've experienced is that health expertise, when you're trying to impact on decisions outside of the healthcare sector, kind of lacks some credibility and power. So that's when you speak on housing or income or taxation policies and so on, as somebody who is seen as having their expertise in health, then your expertise doesn't kind of cross over, and you lose some credibility when you're trying to exert power in a decision that's outside of the health sector. We have a very individual health versus collective population health kind of cultural view, I believe, and that leads to the overwhelming public focus on individual health care. People have all experienced a wait list for a test or waiting in an emergency department, and that sort of reinforces the individual type of a cultural view that we have. So it's very hard for people to get their head around the idea of trying to improve the health of everyone and closing the health gaps, and how that would be better for certainly everyone along the income spread, but for the whole population. And I think that in some ways that's rooted in our Western colonial worldviews, that individual focus, and certainly Indigenous worldviews, I think, are much more compatible with thinking about these social determinants of health and equity at the distribution of power and money and resources. We get into a chicken and egg upstream versus downstream to say, well, we already have so many people on wait lists for acute care. How can we possibly shift our focus or shift our funding upstream? And yet we know if we shifted our focus upstream, then we would have, as we just showed with our data example, we would have less of a burden of health needs downstream. But it's a chicken and egg. Where do you start when budgets and healthcare budgets are already stretched? There is a tendency to silo when you're trying to do health policy across all departments. And I don't think that's necessarily a territorial kind of a negative thing, but people have a tendency to want to, be able to wrap their head around sort of a bite-sized piece of work or a piece of responsibility. And it's very difficult for a lot of people to think as big and as broad and know where the boundaries to their responsibilities might be. And of course, we're in an age where ideology versus evidence is is questioned, and certainly presenting evidence is not in any way sufficient to move the minds of the public some of the time, and the politicians as well. Okay, next slide. Okay, so having said that, I don't want to leave you with feeling not optimistic. So are there opportunities? And I would say yes, I think the door is more open now to moving forward on action on the social determinants of health than it ever has been. And certainly we have the opportunity to mobilize on a health and all policy, or even a child health and all policy. And one of the things I've seen a shift to is, instead of thinking, wouldn't it be nice if everybody, experienced the best possible health, is really looking at a rights-based approach. And I see that coming to the fore a little bit more, I think, and I think we're leaning into that. And the fact that we have inherent Indigenous rights, there's our treaty rights, we have human rights, we have constitutional rights, we have the rights of child, and we have a whole list of rights that really bear on this topic. And so the engagement of those most affected is also powerful, and particularly when it's paired with a rights-based approach. So not just engagement, but empowerment of those most affected, with a strong and powerful voice to weigh into the shifting of the power and resource dynamic. I think there's increasing advocacy momentum and critical mass. And what I see is stakeholders in different areas coming together to build critical mass for policy change. So it might have seemed more fragmented, where people were advocates for housing, or they were advocates for affordable food, or advocates for early childhood development. But now people are starting to wrap those things all together and think of this as one connected tree that we can build critical mass to move together. Demonstrating net cost savings, if we can do a better job of that, might be able to appeal to the fiscally conservative mindsets as well as the community mindsets. So those are just some opportunities I see. Maybe some of you see more. I'd love to hear some of the ideas as well, but I don't think this is a time to ease off on trying to talk about social determinants of health. Next slide. Just about done here and ready to turn it back over to Charlyn. But these are three reports that I've been reading lately that seem like they do come from lots of different health problem areas. So there's the final report from the report on the calls for justice for missing and murdered Indigenous women and girls. Shifting the Lens is a new report that just had come out from the Manitoba Advocacy for Children and Youth, or advocate, for children and youth. And that's looking at deaths for children that are sleep related, that we used to call SIDS. And now this is a new one. The Shifting the Lens is, previously the conversation around that, addressing that health problem, was very behavioral, telling caregivers what to do to protect children. And certainly we want to make sure people are aware of those risk factors. But this report looked at really the determinants of health that were underlying all of the very unequal distribution of children who are dying tragically at a very young infant age, unnecessarily, but they're focusing on the determinants of health. And similarly with looking at climate change in Canada, this is a 2022 report. So all of these things are really focusing not so much on the specific proximal issue, but really on the underlying social determinants of health. Okay, next slide. I think this is where I pass it back to Charlyn. So over to you, Charlyn.
Thanks so much, Sande. That was a very thoughtful explanation of how our understanding has shifted over time. I found this cartoon, and I thought in some ways it was very telling about the way money, power, and the dialogue about how things are working in today's society are working in this era. And, there is a super concentration of wealth among a very, very small percentage of individuals who are trying to make us all compete for other resources. And I think that when we start thinking about how can we begin to address the social determinants of health, we really have to think about these root causes that are causing real unequal distributions of wealth and power and resources. Next slide, please. So why focus on the social determinants of health? And, if we try and capture it as a concept, we can support planning and making arguments, just as Sande has done, to argue for more effective policy approaches and develop opportunities for action. And I think some of the thought experiments that Sande did helped you think about, how do you make those arguments? How do you put them in front of people? And so over the last few decades, our understandings of the social determinants of health, you've heard, have expanded to recognize the complex, interrelated, and multi-layered nature of determinants that work together to shape health, as well as the wider set of forces and systems that shape the conditions of our daily lives. So any attempt to address the social determinants really has to work at those deeper levels as well. How do we do that? Not a lot of easy answers there, but to date, any thoughts about policy have said that we really need to think about a broader set of policies, of social policies, that can help us address some of these inequities. Next slide, please. So there have been many attempts to try and talk about, okay, how do we need to address this? We start at social determinants. We can talk about social services, but really what we really need is social justice at the end, right? And we really need to be working to think about that as a way to move forward. And so, what are some examples, though, of some of the areas where there has been some concerted thought about policy responses? If I can have the next slide. Really have tended to focus on some of these key areas, right? And although we need health across these areas, we do need to focus on key issues. And health equity is one. Improving early childhood development is really another area that really needs to be focused on, and is one that it's an area, I think, where there is a larger amount of public sympathy to ensure that our next generation is healthy. Fair employment, decent work, social protection, living environment. Next slide. I'm going to whiz through these because I really do want to leave time for discussion. I think that this slide really shows an understanding of the differences between reality, equality, equity, and justice. And when we tend to think of equity, people don't have an understanding of what's really required to get there. And they tend to think of equality. So you can see this diagram is used quite frequently to talk about, this is, I think, the reality is very close to that first slide I started with. Some people have much better views of the game and much better access to seeing and controlling what goes on than others. Some people just manage to peer over the fence, and some people are in a hole in the ground. That's our current reality. Equality would be putting everybody on the same box, but some people would still not have access to the game. Equity means that you give a distribution of resources so that everybody gets to see what's going on. Everybody's lives are improved. And justice is, there's no fence. You don't need boxes to stand on. So I like this as a way of, helping us bring forward the message to policymakers about what we really need to strive for. I think this is a good little diagram. But, next slide. Typically, we have ways of thinking about addressing these different areas. And I'm not going to go into these, but obviously any policy initiatives need to shift from the medical care system to a completely different field of view, to look at comprehensive whole of government strategies to address health equity, not just in the Ministry of Health. Democracy and empowerment are part of this. Equity and justice is the justice, as I showed in my previous slide, are really critical, important areas. I've got one more example in the next slide of, social protection. And you can see there are a number of different specific approaches that could be used here, but, increased coverage, replacement, decrease inequity in financial supports, reallocate current expenditures, extend Social Security contributions, prevent discrimination to potential recipients, and manage and deliver social protection. These are the kinds of more specific policy initiatives that need to be initiated across government to address some of these issues. So next slide, and I'll turn it back to Sande, and then I think we're going to wrap up and move over to questions. Sande, back to you.
Sorry, I was muted. Thank you very much. Yeah, that was really interesting, Charlyn. I just wanted, I know we're just sort of scratching the surface here today, and we've thrown a lot of kind of concepts and layered concepts. So I just wanted to leave you with a couple of places if anyone was interested in digging into some more information. So in Canada, we have national collaborating centers that were under the across the country on different topics. And so this is one that is, I find a really good one. So we have a National Collaborating Center on Determinants of Health. And so there's a document that that tree diagram came from that was called from the Let's Talk series, Let's Talk About Determinants of Health. And they also have a curated list, which is 13 other documents that are sort of key documents with the concepts that we mentioned today, that are not all their documents, but they've sort of curated a broad spectrum of documents that delve deeper into some of the specific concepts. So that's a really good resource. It's just Google or go to the National Collaborating Center for Determinants of Health. And then on the next slide, the other resources specific to the Determinants of Health for Indigenous people. And so there is a National Collaborating Center for Indigenous Health. That one's situated in Prince George, BC. And there's some really good resources. The one on the left is one that's available on their website. So it's a document that you can just download and read, and it has the first tree diagram that I showed you, and all of these resources are written by Indigenous scholars, knowledge keepers, contributions from poets and artists, and so on. So it comes from an Indigenous perspective written by Indigenous people. So I think we didn't, up until recently, we didn't have resources like that was coming from an Indigenous worldview as authentically as that. And these are really valuable documents. The other two are sort of textbook-based ones, and they're I think they're available for purchase, and I don't think they're available sort of as an online read. But the last one, The Determinants of Health, Indigenous Peoples' Health, that one's in a second edition now. The first edition was 2015. So we really are standing on some really solid resources if we want to learn more from Indigenous perspectives, hearing Indigenous writers around what determines the health of Indigenous people. So I just want to put in a plug for those documents as well, if anyone's curious to delve a little deeper into any of the things we've talked about tonight.
Thank you so much. They will be very helpful in our policy work at the Green Party. Sande, thank you.
And I just wanted to say I dug out that income distribution. If you wanted me to circle back to the question that was asked about the income cutoffs and the quintiles.
Yes, please do.
Do you want to do that right now? Okay.
Yes, Paul's question.
Yeah, so that's available in an appendix in that RHA data report. So that's publicly accessible data. But for this particular, they would shift around and change depending on which year. This was based on the 2011 census. And so income quintile 1, the lowest, it spans from about 14,000 to 46,000, or no, 14 to 50,000 for the lowest income quintiles. Quite a wide range. It's pretty much everything under 50,000. Income quintile 2 is 50 to 63 or 64. Then 64 to 81 is the third income quintile. 81 to almost 100,000 is income quintile 4. And then income quintile 5 gets large too, because it's sort of like everything over $99,000. So up to 343. But so those are, and it's not individual income, but it's based on the income in a dissemination area. So that's an example of the income cutoffs for that particular year, and they would shift around a little bit. But you can see that a lot of the depth of poverty exists in the income quintile 1.
Thank you very much, Dr. Harlos. I understand that Charlyn, Dr. Black has to leave us at the bottom of the hour. So any questions or any other comments you would like to make, Charlyn, before you have to depart? We're going to continue on till 9, folks, and I'm hoping there'll be much more discussion and input onto our green policies that we want to promote and encourage the decision makers to adopt. But before we do that, I do welcome any more comments and feedback from Dr. Black.
Hi, thanks very much. I will say that I have really felt a privilege to work with you and to connect with you and to share some ideas. I'm sorry, I was under the impression that we were just online for an hour, so I'm going to have to miss further discussion. But I do commend you, the Green Party, for looking into these issues and for thinking about how do we start to advocate for addressing these issues in a wider, broader, and deep in the roots way. Mm-hmm. And how do we support research to be able to make us those arguments in a very powerful way? So I wish you the best with that agenda going forward.
Thank you so much. We're not anticipating any kind of power position, but I think the fact that we're outliers gives us the opportunity to put forward and share with the other parties.
Right. Well, and you may note that the BC Greens may be in a position to wield a lot of power
with just 2 seats. So yes, exactly.
Had there been proportional representation, they would have had 8 seats. But so I think that there's a real role for the Green Party to make a difference.
Yes, thank you so much, Dr. Black. We agree. We agree, and that's one reason why we're holding this monthly series with what we think are very important topics for discussion to make policy and policy development a little less esoteric and more everyday meat and potato stuff. Or being vegan oriented. I apologize for using that term. Beans and potatoes. How about that? Okay. Great. Well, we're open for discussion. Anyone like to share some of their reactions to this? Any comments or questions you would like to have? As I say, Dr. Black will be leaving very shortly, but Sande, Dr. Harlos will be staying with us. So
perhaps you could unshare the screen so that we could have more people visible on screen.
Thank you, Paul. Excellent idea. Dennis, if you could. Great. Well, okay, there's Greg. Go ahead, Greg.
Thank you. I think one of the biggest challenges that we have is exemplified in that old cartoon that you had displayed. We have an issue not just in healthcare, but across the entire economic community with the movement of private wealth public wealth into private hands. And I think this is just another example. What makes it difficult to change these sorts of things is that people who are making the profit, who are getting the money, are going to resist profoundly any sort of change that removes their revenue. So I think that in terms of strategy, one of the things that needs to be front and foremost is understanding how this is going to be addressed. Pretending that this will just magically go away is not going to be effective. We need to call out the elephant in the room and understand, granted, I would rather see it one spoonful at a time than social disruption, but we need to understand what is the approach for eating the elephant. Thank you.
Yeah. If I can just quickly respond to that, I mean, one of the Lancet has had a really good series on the commercial determinants of health. So for the first time in this trajectory, there has been a naming of that, of the profit motive is creating so much bad food, so much bad climate, right? It's really, really destroying our health. So the Lancet and the WHO, and for the first time, the BC Public Health, I think it's the first time a public health association has started to have a conference on the commercial determinants of health. So we're starting to name that. And I think it's critical that we do that, because otherwise, if we're just talking about roots and underlying determinants and we're not talking about the elephant in the room, we're going to miss the opportunity to bring things out into the open. So I could not agree more. And that's why I think that little graphic is so the two graphics are so powerful. So thanks very much.
Thank you so much for joining us tonight,
Okay.
Dr.
And I'll say
Black.
adieu. Okay.
And thank you for your excellent ongoing work. Very inspiring.
Thanks. Okay.
Good
Bye.
night. Okay, well, that is just to build on that. That is largely why we want to have these series and these discussions, is to inspire us to support our policy. And in that, just before we go further, I want to take this opportunity, Gilles, to thank you so much for the work you've done on our policy page and our website that make accessing specific policies that people are interested in so much easier. So we will be announcing this to our members later on, but our website and the policies listed on our website are far more accessible than they've been before. So we're excited about that because we're very proud of them and we want to continue working with them. So not to take too much away, but just have to acknowledge where that's due. And so others that would like to comment or question.
I have a comment. I'm just curious about the whole, if it's changing a little bit where those with more money perhaps are having less health due to the unhealthy food that they have access to now, perhaps more meat, more eating out, more all of that. Apparently now our life expectancy is decreasing. Obesity is increasing. Not obviously that they have the challenges of the lower income people, but I'm just wondering if it's shifting a little bit where some of the wealthy people are experiencing more ill health now because of their privileges that they have, having access to some more of these unhealthy behaviors.
Well, I'll just personally say I think that might be more in the middle class, Laura, because, for example, as far as I know, the upper health, sort of the upper crust, those highest percentiles, they're eating organic. They're vegan. They're knowledgeable. They have access to the research that lets them know what they have to do to live long and be healthy. But I also want to say Mary Jane indicated she wanted to speak, and Paul. So Mary Jane, if you want to go forward, and then Paul. Oh, you're muted, Mary Jane. Please unmute your microphone. There's an
Can you hear me
icon.
now?
Yes, we can hear
Okay, good. It was during the COVID time, I remember, this was very shocking, but it fits into the determinants of health that the speaker was talking about. They closed the Misericordia Hospital. The Misericordia Hospital was a hospital in the community that the people that are on low income, people that did not have cars, people that had to walk to their places to get medical care, they had no place to go. So that had a lot of ramifications. I don't think anybody has really looked into the ramifications of what has happened because of these kinds of things. And now we wonder why there's so much violence and so much gang membership. So this was one of the things that happened. They determined that they were going to close the Misericordia Hospital. And so without consulting with people at all. And so that was very upsetting. And that, I think that is one of the determinants of health that was shown, because they had all these different ideas about how they're going to fix the hospitals and so on. And another thing about food, I'm always in a dilemma because I'm having cooking classes. I have to admit that we can buy organic food. We can't expect people on low income to buy organic food. So I've been buying some canned tomatoes that says non-GMO. It's twice as expensive as regular tomatoes. But there's so many foods that would be so much healthier if we could eat organic. And we are not allowed, the economic situation does not allow people to do that. So that's one of the realities that we have to try to rectify. I don't know how.
Yes. Well, one thing I'll just point out briefly before we'll go to Paul, and then others be thinking what you want to contribute, is that as far as I know, tomatoes are not genetically engineered other than by normal breeding methods. So for them to be stating that they're non-GMO is a marketing term. And what others should also know is
that's a good point. Yes.
Yes. But before we move on to Paul, I just want to ask Sande if you have responses to what's been put forward so far, what Mary Jane's concern about the hospital closure, and I'm trying to think of what the one just prior was, but if you have any comments you want to respond.
Yeah, I think one of the comments was, are people in the highest income quintile having poorer health because of some of the, and so, I'm trying to, I think I did see at one point one particular indicator, and I think it was related to something cardiovascular, where income quintile 4 and 5 on a particular income was very similar, and 4 was a little better than 5, and it was postulated that some people in the very, very high income was experiencing a higher burden of stress in the roles that they had, and sometimes income quintile 4, when you have a lot of material, fair bit of material advantage, but you don't have maybe as high of a stress, we're doing better. But other than that one exception that had caught my eye several years ago, I think that in general that income that gradient kind of persists. And I even looked a little bit in what happens if we take the lowest income quintile and disaggregate it into smaller bits, like little 5 income quintiles inside of income quintile 1, and the same pattern of a gradient exists. And the other thing I wanted to point out with that, though, but that's presuming that the people in the highest income are experiencing the best possible health, and I don't think that's true either. So whenever we think about social determinants of health, our goal would be twofold. One would be shifting the whole population to be healthier. There's a lot of unmet potential for everybody across all income gradients to being healthier if we had a more equitable distribution and more social justice and all of the, both the material and social and spiritual conditions that optimize health. I believe that highest income quintile certainly could do better as well. But the biggest, social injustice is that right now, compared to those who are kind of do invest in our situation that we have such gaps, and some people are doing so much more poorly by comparison. I can't say much to the distribution of the moving of the hospital. And again, that's part of the determinants of health, would be healthcare access and so on. Certainly in the States where there isn't funded healthcare really as available, those are still very big issues for many parts of the world. But the social determinants of health typically don't look to that. But I don't think there was enough. Personally, I don't think there was enough study done on the impact of those most vulnerable when that particular decision was made.
Thank you so much, Sande. We're going to go to Paul and then Chris. But Paul, just before I turn it over to you, I'd like to draw folks' attention. If you'd like a link, Debbie has kindly put a link in the chat where she was in the right place and the right time to do an interview on the Misericordia closing. So she's one of our green counselors. I'll use that as an opportunity to invite those of you that aren't members to be members or renew your membership and support, because we do have an active, strong team in place that we would love you to join. So with that little promotional blurb, I'll turn it over to you, Paul.
Yeah, thanks. I just wanted to underline the need to look at what one of our presenters called the commercial determinants of health. The capitalist economic system writ large imposes a certain kind of discipline on society and certain values which work against health. Competition versus cooperation, for example, funding things that are profitable rather than things that are helpful. If we want to talk about poor people can't afford good food, but simply giving people more money doesn't necessarily mean they're going to eat good food. When we're thinking in terms of policy, maybe an approach would be to take the good food issue, maybe a provincial government that found a way to incentivize the production of cheap organic food that could be made available at reasonable prices, even if that meant going into competition with the Loblaws and the Safeways and the Sobeys and so on and so forth, and force them to meet people's needs. So I mean, thinking more holistically, I'm reminded of Cuba, tiny little country. They're having a horrible time economically. During the COVID pandemic, they dispatched medical teams around the world to help out in other parts of the world. They were able, they produced so many doctors they could do that. They developed their own vaccines. They offered to send medical teams to work in First Nations communities in Manitoba, but they were turned down by the federal government. So a tiny little socialist country hitting far above its weight in terms of providing health care both to its own people and to people in poor countries right around the world, and not so poor. They sent teams to Italy, for goodness sakes, to help when that medical system was collapsing back in 2020. Anyway, I'll stop there. But let's not get hung up in the technocratic stuff, and let's not worry too much about whether we have 5 hospitals or 6 hospitals. Maybe we'd be better off with 1 hospital and a better food system.
Thank you. Well, that the role the food system plays is huge in my analysis. But let's turn it over to Chris now. Chris, please go ahead.
Okay. So a couple of things. First of all, I'm glad that Paul mentioned the word capitalism, because when you look at the roots of everything, capitalism is at the roots of all the inequalities and all the oppressions. And it's the economic system that's created that. And as Paul said, the ideology is entrenched in us. So it's a dominant ideology. They have hegemonic power over the thought processes that go on. I'm glad that Paul was mentioning that because I was going to bring it up. But I guess the challenge for the Green Party of Manitoba is, how radical do you want to be? I hope the Green Party of Manitoba would want to be totally radical and call a spade and say, okay, this is the reality. So that's the first point. The second point has to do with the quintiles. So when you look at the bottom 20% of the people in Manitoba that are struggling with health outcomes and the injustice of that, we had a speaker a while ago, Sid Frankel from the University of Manitoba Faculty of Social Work. He was talking about the basic income and promoting the idea of the basic income. Now, I guess I was disappointed listening to him at the end, because he's been in conversations with Nahani Fontaine, who's in charge of that department that would provide the income. And they're not looking at instituting a livable income for people in Manitoba at the present time immediately, which is what is necessary. They're looking at incremental steps, which is basically meaningless. So I would hope that the Green Party of Manitoba would ignore what Sid Frankel said about Nahani Fontaine's approach and say that is totally inadequate and we need to go immediately. If people are concerned about where's the money going to come from, there's subsidies we can eliminate and there's wealth taxes we can impose on people. So we should be able to sell it as a revenue neutral thing, which will promote that social justice and improve the quality of lives of all those people in the bottom 20%.
Absolutely, Chris. Completely agree with you. And then again, there's that data that we started off with, that the amount we would save of costs in our healthcare system would cover that kind of support.
Yeah.
So thank you. Yes. And for those of you that don't know, I believe that I'm here today capable of serving as the leader of the Green Party because randomly the rooming house I was living in as an abandoned 16-year-old was chosen to be part of the Mincome program. And that gave me the support to go back to school. And I think to get away from the drugs and alcohol, that culture that I was in danger of being consumed by, but having the support for my education made a huge difference. So now let's hear from Debbie. Please go ahead, Deb.
Hi, I'd like to just pick up a little bit on the idea of subsidies that Chris mentioned. Like in 2019, Canada passed created its food guide, which was created by 37 researchers after 3 years of study and no industry influence. And you can take a look at the lovely plate yourself, but it is composed almost entirely of whole plant-based foods, but we continue to subsidize animal agriculture to the tune of billions of dollars. So we need to really shift our subsidies to make the healthy foods that are recommended by the Canada Food Guide more affordable and available to all.
Yes, and we will continue to work on our agricultural policies. Just to piggyback on that, to use a term for the animals that I would like set free in Manitoba. I believe the last few times I've gone into a grocery store, I've estimated that 80% of the food in that store should not be considered food. It would be detrimental to health, in my opinion, and is some kind of weird form of entertainment that they're making money on, and certainly does not contribute to health in any way, and in fact actively destroys health in people because of the amount of salt, sugar, and fat that's in it. So anyway, that's my little rant. Who else would like to make a comment? We've got another 10 minutes before we have to close up, and we're really pleased that you folks are here. There are some voices we haven't heard from. Anyone that hasn't spoken yet like to make a comment or say something about, I will say Gilles has again been very resourceful for us and has put the link to the 2019 RHA Indicators Atlas on the MCHP website. So that's in the chat if anyone wants to follow up on that paper. Thank you very much, Gilles, for that. Okay, Laura, please proceed.
Yeah, I'm just curious what Dr. Sande would think of basic income and if that's sort of in discussions in your field, if it's ever been discussed even casually, and what the thought is out there in the medical environment as to what that could change.
Yeah, no, so I mean, I'm retired from my paid job, but the Manitoba Public Health Association is certainly in full support of the guaranteed livable basic income. So we were certainly supportive in advocating for the bill C-223 that was defeated in second reading, unfortunately, to look at a framework for guaranteed livable basic income in Canada. Certainly, we also advocate for looking at how to move towards that in Manitoba. So that has certainly been one of our areas of focus that we think is a huge tool to address the inequities in the conditions for basic living. I think, again, when we were trying to make the distinction or look at the fulsome picture of addressing the social, addressing the conditions aspect of the social determinants of health, but also that redistribution of power and money and resources. I think it certainly would be, in a sense, a stopgap to make sure that everybody has at least a basic income. And I don't think we would stop there, though, because we still would want to shift the power structures underlying that is keeping people from full participation in their choices and self-determinations. And that's particularly true of Indigenous individuals and communities. But yeah, we fully support, I think from a public health perspective, broadly, that makes so much sense in the impact that it would have for health. And we know that from the MinCom study here. We know that from other sort of semi-pilot projects, that the benefits to health are pretty immediate, particularly the mental health benefits, but certainly a lot of other health benefits as well. And it didn't run long enough to know some of the longer term health benefits, but if it can run for only even a few years and show health benefits and reduced demands on the healthcare system, imagine what it could do over the longer term. So yeah, it's definitely something that we should be supporting.
Exactly. Good to hear.
Absolutely. Completely agree. Just want to share what Greg put into the chat, that we need to eliminate lobbying. Lobbying undermines democracy. And I can't agree more, because lobbying by the so-called life science companies that provide the synthetic pesticides and fertilizers used in the majority of agriculture in Canada is a big reason why we've had to hire, we being Canadian Organic Growers, Canadian Organic Trade Association, and the Organic Federation of Canada, we've had to hire our own lobbyists to get heard about how the incredible amount of carbon sequestration and ecological services that resilient organic agriculture provides, and they're not including us in the programs of support that are really, when we look at them, really not effective ways of ensuring that agriculture reduces the 30% of greenhouse gas emissions that it's responsible for in Canada today. So those lobbyists are doing a lot of real serious damage. So I completely agree with you. So before we've got just a few minutes left. Yes, please, Debbie, go ahead.
In New York, the mayor, Eric Adams, had reversed his type 2 diabetes by adopting a whole food plant-based diet. And now the hospitals there are plant-based by default. And it's my understanding that a similar project was piloted in Vancouver. And I'm just wondering if Dr. Sande has any words of wisdom regarding that. I'm especially interested, on cost savings, and if they're noticing any improved health incomes as a result of doing that. Thank you.
Excellent. Dr. Sande.
Yeah, I don't have any direct experience in that. I think that one of the things that's being recognized in the broader sort of planetary health discussion is that not only around foods, but around a whole lot of practices and processes, that healthcare institutions are pretty bad actors when it comes to emissions and and a variety of impact on the environment. So I think there's a lot within the healthcare sector that can be done within healthcare services to think about the food services provided both for patients and staff, but also thinking about a lot of the other processes that happen within a healthcare facility and in what ways the environmental footprint and the emissions and so on could be curbed, because there are some best practices to look at out there. But having said that, I know when in my working life, I was trying to work on some healthy policies and for our own healthcare system here, and there's just a lot of resistance to get beyond in terms of a lot of times the relationship or the contracts and the financial impacts of contracts with either franchises or with vendors that provide the food for hospitals. So there's a lot tied up in those contracts and what seem to be sort of cost savings. So there's a lot of challenges, but I don't think that should stop anybody from pushing for healthy foods and a really look at the environmental impacts of a variety of processes within healthcare.
Excellent, thank you. That reminds me, your answer there reminds me of one of the key takeaways that I had from today's presentation before I go back over to Deb, just that redistribution of power that is required for true health equity. And those that are invested in the current power system, the current inequitable power system, they don't want to give it up lightly. So that's where we have to be as strategic as Greg said we should be. And Greg also has put some interesting information in the chat again. The Finnish experience with a universal basic income has been hugely positive and beneficial, and he's shared a couple of links with us there. So thank you so much for that link, Greg. Excellent. And now I thought I saw a hand up. We've got a few moments left.
I was just giving Dr. Sande a thumbs up.
Oh, a thumbs up. Okay, you were agreeing. Excellent. Yeah, because that's really what a lot of the issues that we're having in having a more local organic agriculture that it makes food accessible locally, so that it's much more equitable in its distribution. Because I'm sure everyone on this call knows that the reason that we have an increase in people starving is not because we're not producing enough food. It's a distribution issue. And I think it's unconscionable that in this day and age, we're actually seeing an increase in hunger in the world as opposed to the opposite. So we just, those people that have their hands on the power, we have to be very active. And in the interest of that activity, I just would like to take a moment to say that we have some very interesting panelists confirmed for our next series, which is Wednesday, November 27th. We would welcome those of you to consider attending, on the impact of our food choices on the climate emergency and the environment, the importance of a plant-based diet. We have panelists confirmed: David Steele, President of Earth Save Canada, and Professor Jason Hannon from the University of Winnipeg. So we're hoping to have another dynamic session on the 27th of November. But I just want to close by saying thank you so very much, Dr. Harlos, Sande, for all the information that you and Charlyn have shared with us this evening. We are continued to be inspired by the work that you do, and that there are like-minded folks out there who see the values that have to change and the kind of power dynamics that have to change for there to be a more equitable health system in Manitoba and across the country. So we're hoping to continue to speak loud and firm on that. My most recent letter to meet with several of the ministers was just recently answered. No, they won't be able to meet with the coalition of us that wanted to speak to them about the state of the hog industry in Manitoba and why we should be moving away from supporting that that torturous system and that food production that creates so much pollution in Manitoba. But we will continue. We'll be continuing to write and to respond. We have had some letters to the editor in recently. We're going to continue to be as verbal and make as much of a joyful noise for change and for the redistribution of power for more equity across. So I'd like to thank very much Dennis for all the work that you put into arranging tonight's session. Dennis, thank you so much for that. Thank you, Laura, for the timekeeping. I think we managed to have quite a good presentation without anything going on too long. And thank you all very much for coming. Please do renew your memberships if they've lapsed, and think of others that you know that you might want to invite to join us, because that membership really does give us a good solid foundation. So once again, thank you so much, Dr. Sande Harlos. All the best for your continued work, and thank you all for coming this evening. I hope to see you on November 27th, if not before. All the best, everyone. Be well.
Thanks.
Yeah.
Thanks for
Thank you,
having us.
Dr. Sande. It was terrific.
Thanks very much.
Thank you, everyone.
Good night.
Good night.